Welcome to Last Minute Lecture. This free chapter overview is designed to help students review and understand key concepts. These summaries supplement, not replace, the original textbook and may not be redistributed or resold. For complete coverage, always consult the official text. Usually, when we think about the human body, we picture this, slow to adapt, stubborn machine. I mean, you get a cut, and it takes days to heal. You want to build muscle, and it takes months at the gym.
Right. It's a slow process.
Yeah, exactly. But then you step into an emergency. Like, imagine a car suddenly swerves into your lane on the highway, or you hear a loud, unexpected noise in the dark. Instantly, in just a fraction of a second, your body completely rewires itself.
It really does. It's amazing.
Your pupils blow wide open to take in more light. Your heart just hammers against your ribs. Your airways expand to pull in more oxygen, and blood is immediately shunted away from your skin and sent straight to your skeletal muscles.
It is the ultimate evolutionary survival mechanism. That instantaneous transformation is the classic sympathetic nervous system reaction, widely known as the fight or flight response.
Right.
And it's strictly designed to keep you alive when seconds matter.
And as a nurse, you don't just get to witness that physiological marvel. You actually get to command it. You can hold that exact, incredible evolutionary power in a tiny IV bag.
Which is a lot of responsibility.
Huge responsibility. And that is what we are exploring today. Welcome to the deep dive. Our mission today is to help you, the nursing student, master Chapter 20 of Lynn's Pharmacology for Nursing Care. We're looking at adrenergic agonists.
Yes, and you'll often hear them called sympathomimetic simply because they mimic that sympathetic nervous system response we just talked about.
Exactly. We are going to explore the underlying chemistry, the specific receptors they target, and most importantly, how to apply this knowledge safely at the bedside. Because once you understand the underlying mechanics of how these drugs work, the clinical implications become entirely logical.
I love that.
Yeah, you won't have to rely on rote memorization anymore. It just makes sense.
That is the perfect approach. I mean, to really grasp these medications, you have to start at the cellular level. We need to look at how these drugs actually turn the system on.
Okay, let's get into it.
So there are 4 basic mechanisms by which drugs can activate adrenergic receptors, but the most critical distinction to understand is the difference between direct and indirect activation.
Direct versus indirect.
Right. Direct receptor binding is by far the most common mechanism in pharmacology, and it is the primary focus of almost every drug we will discuss today.
Okay, so if we visualize the body's receptors like a light switch in a room, direct binding makes a lot of sense. The drug enters the bloodstream, travels straight to the receptor, and physically flips the switch itself.
Exactly. It acts as a perfect molecular mimic for our natural neurotransmitters like norepinephrine or epinephrine or dopamine. The drug is doing the heavy lifting directly.
So if that is the direct route, how does a drug turn the system on indirectly?
Well, sticking with your analogy, indirect activation is like messing with the room's electrical wiring so the light stays on automatically without the drug ever actually touching the switch itself.
Interesting.
Yeah, and there are 3 ways a drug can do this. First, it can promote the release of natural norepinephrine from the nerve terminals, essentially flooding the gap with the body's own chemicals. Amphetamines and ephedrine work this way.
Okay, so pushing more of the body's own chemicals out.
Right. Second, a drug can inhibit the reuptake of norepinephrine. Normally, the body is constantly recycling these transmitters to turn the signal off, but drugs like cocaine or tricyclic antidepressants block that recycling mechanism.
So the norepinephrine gets trapped.
Exactly. It gets trapped and is constantly stimulating the receptor.
So the body's own natural off switch gets jammed.
Precisely. And the third indirect method is inhibiting the inactivation of norepinephrine by an enzyme called monoamine oxidase, or MAO.
MAO, okay.
Think of this enzyme as a cleanup crew. If you disable the cleanup crew, the transmitters linger and continue to activate their receptors. But again, when we look at the peripheral nervous system in an emergency setting, we are almost exclusively utilizing drugs that walk right in and flip the switch directly.
Which brings us to the actual physical structure of these direct-acting drugs. There is a massive divide here between 2 chemical families, right? The catecholamines and the noncatecholamines.
Yeah, it's a very important distinction.
And on a molecular level, the difference is microscopic. A catecholamine contains a catechol group, which is really just a benzene ring with 2 hydroxyl groups and an ethylamine component. Non-catecholamines have that exact same ethylene piece, but they are completely missing the catechol group.
Just that one little piece.
Right. It sounds like a purely academic detail, but how does that missing group actually change things for a nurse administering the medication?
Oh, it changes absolutely everything. Knowing whether a drug is a catecholamine or a non-catecholamine instantly dictates your entire administration strategy. It tells you 3 vital things.
Okay, what's the first?
First is oral availability. Catecholamines cannot be given orally. They will never survive the digestive tract.
Wait, is that because of stomach acid or something else destroying them?
It's the body's natural defense mechanisms, specifically enzymes. We mentioned MAO earlier, and there's another enzyme called EOMT. These enzymes are heavily concentrated in the liver and the intestinal wall, and they are incredibly aggressive.
So they just chew the drug up.
Exactly. If a patient swallows a catecholamine, MAO and COMT will completely destroy the drug before it ever has a chance to reach systemic circulation. But non-catecholamines, because they lack that specific catechol group, are effectively invisible to those enzymes.
Oh, wow.
Yeah, they resist destruction and therefore can be safely administered by mouth.
That makes so much sense. That explains why we see things like epinephrine given as an injection, but pseudoephedrine can be taken as a pill. So what is the second major difference?
Duration of action. Because catecholamines are so vulnerable to MAO and COMT throughout the body, they have an extremely brief half-life. I mean, they are metabolized almost instantly.
Which means you have to keep giving it.
Right. That's why, in an ICU setting, you will see drugs like norepinephrine or dopamine administered as a continuous IV infusion. If you turn off the IV pump, the drug's effect vanishes within minutes.
Wow.
Non-catecholamines don't get broken down nearly as fast, so their therapeutic effects last much longer.
And the third major difference relates to the brain, right?
Yes, brain access. Catecholamines are highly polar molecules, and polar molecules carry an electrical charge that prevents them from easily crossing the blood-brain barrier.
So they don't affect the brain.
Exactly. They have minimal to no effect on the central nervous system. Non-catecholamines, on the other hand, are far less polar. They can slide right across that barrier and trigger significant central nervous system effects.
So as a quick mental checklist for you listening, catecholamines mean IV or injection only, a very short duration requiring continuous drips, and no central nervous system effects. Non-catecholamines mean oral dosing is perfectly fine, they have a longer duration, and they can cross into the brain.
That is an incredibly reliable framework.
And there is a crucial clinical safety alert that goes along with catecholamines that the textbook points out. When you pull a catecholamine FOV solution like dopamine or epinephrine from the automated dispenser, it starts out clear and colorless.
Like water.
Right. But these molecules are unstable and can oxidize over time. If you look at that solution and it has turned pink or brown, you must discard it immediately. The drug is degrading and is no longer safe or effective.
Yes, though it is worth noting the text points out one highly specific exception to that rule, which is dobutamine.
Okay, dobutamine.
Dobutamine can safely be used for up to 24 hours after it's been mixed, even if a slight pinkish discoloration appears. But for everything else in that family, discoloration means it needs to be wasted according to your hospital's protocol.
Got it. So we have the keys, the drugs themselves. Let's talk about the locks they fit into. This is the concept of receptor specificity.
The fun part.
Yeah. The nervous system has different types of adrenergic receptors scattered throughout the body. We've got alpha-1, alpha-2, beta-1, beta-2, and dopamine receptors, and not every drug fits into every lock.
Exactly. You have to view receptor specificity on a spectrum. On one end, you have highly selective drugs. For instance, albuterol is highly selective. It prefers to only bind with beta-2 receptors.
Okay.
Then you have drugs with a broader reach, like isoproterenol, which will happily bind to both beta-1 and beta-2 receptors. And on the far end of the spectrum, you have the master key, which is epinephrine. Epinephrine activates alpha-1, alpha-2, beta-1, and beta-2.
I want to pause on that concept of selectivity for a second. If I have a patient taking albuterol and the literature says it is highly selective for beta-2, does that mean the heart, which is packed with beta-1 receptors, is completely safe from being stimulated?
That is a trap that catches a lot of clinicians off guard. The critical principle here is that selectivity is relative, not absolute. It is heavily dependent on the dose. At low to moderate standard therapeutic doses, albuterol will stay in its lane and only bind to the beta-2 receptors in the lungs.
But that they take too much.
Exactly. If a patient takes an abnormally high dose or takes it too frequently, the sheer volume of the drug overwhelms the system. It loses its selectivity, spills over, and will absolutely start binding to those beta-1 receptors in the heart, leading to cardiac side effects.
That is a massive distinction. Selectivity is a preference, not a guarantee. So what actually happens when a drug successfully binds to one of these receptors? Let's walk through the clinical consequences, starting with alpha-1.
Okay, so alpha-1 receptors are primarily located in the blood vessels in the eyes. When you activate an alpha-1 receptor, the primary response is intense vasoconstriction. The blood vessels sharply narrow and clamp down.
And therapeutically, you can do a lot with that mechanism. Like if someone has superficial bleeding, constricting the local vessels will stop the blood flow. If a patient is severely hypotensive in shock, widespread vasoconstriction will elevate their blood pressure.
Very useful.
It is. It's also used to relieve nasal congestion by shrinking the engorged capillaries in the nasal cavity. And in the eye, alpha-1 activation causes mydriasis, which is the dilation of the pupil, very useful for ophthalmic exams.
But that same intense vasoconstriction is responsible for the adverse effects.
Right, the dark side.
The most immediate danger is severe hypertension. If you administer a potent alpha-1 agonist systemically via IV, you are clamping down on the entire vascular network at once. The blood pressure can skyrocket to dangerous levels. And the other major hazard is localized tissue necrosis. If an IV line running an alpha-1 drug infiltrates, meaning it slips out of the vein and the fluid leaks into the surrounding tissue, that powerful vasoconstriction happens right there in the local tissue bed. It restricts the blood flow so severely that the tissue is literally starved of oxygen and dies.
That makes perfect physiological sense.
Okay.
But here is something that often confuses people in the text. If alpha-1 activation causes widespread vasoconstriction to drive up blood pressure, why is bradycardia, a slowed heart rate, listed as an adverse effect?
That's a great question.
I mean, you would assume a massive sympathetic nervous system stimulant would put the heart into overdrive, not hit the brakes.
It seems completely counterintuitive until you factor in the body's autonomic feedback loops, specifically the baroreceptor reflex.
The baroreceptor reflex.
Right. When an alpha-1 drug causes that sudden widespread vasoconstriction, the blood pressure spikes rapidly. The body has built-in pressure sensors baroreceptors located in the carotid, sinus, and aortic arch.
And they detect that spike.
Exactly. When they detect this dangerous spike in pressure, they panic. They send a distress signal to the medulla in the brain. The brain responds by sending an impulse down the vagus nerve directly to the heart, ordering it to slow down immediately to try and lower the pressure.
Wow.
So the drug itself didn't slow the heart. The body's desperate reflex to fight the drug's effect is what caused the bradycardia.
That is a brilliant example of the body trying to maintain homeostasis against an outside intervention.
Yeah.
What about alpha-2 receptors?
We can be quite brief with alpha-2. Activating peripheral alpha-2 receptors has very little clinical significance. Activating central alpha-2 receptors in the brain can reduce sympathetic outflow, which is a mechanism used for treating hypertension, but that is generally managed with specialized drugs covered outside of the standard sympathomimetics chapter.
Good to know. Moving on to beta-1 receptors. A helpful memory trick here is that you have one heart, so beta-1 primarily affects the heart.
Precisely. Activating beta-1 receptors has a powerful positive inotropic effect, meaning it significantly increases the force of the heart's myocardial contraction.
Okay, this is a critical intervention for a patient in heart failure whose heart is pumping weakly. It also increases heart rate and cardiac output, which is essential for managing shock. It enhances electrical conduction through the AV node, helping to overcome an AV block.
And in a code situation.
Right. In the ultimate emergency, a cardiac arrest activating beta-1 can help restart a heart that is completely stopped.
But pushing the heart to work that hard has undeniable consequences. The adverse effects include tachycardia, where the heart beats dangerously fast, and dysrhythmias.
Yes, you have to watch the monitor closely.
And the most critical adverse effect is angina pectoris, or severe chest pain. When you force the heart to beat faster and contract with more force, its demand for oxygen skyrockets.
Exactly.
If a patient has underlying coronary artery disease, their compromised vessels simply cannot deliver that extra oxygen. That mismatch between supply and demand is what triggers the angina.
Very well explained. Now, let's look at beta-2. Following your memory trick, you have two lungs, so beta-2 receptors are primarily found in the lungs, as well as the uterus. Okay, two lungs, beta-2.
Therapeutically, activating beta-2 causes bronchodilation. It relaxes the smooth muscle surrounding the airways, opening them up. For a patient suffering a severe asthma attack, this is an immediate lifesaver. It also relaxes the smooth muscle of the uterus, which can be utilized to delay preterm labor.
The adverse effects here are interesting because they connect directly to where else these receptors live. For example, a major side effect of a beta-2 agonist is a fine muscle tremor.
Yes, very common.
That happens because there are beta-2 receptors embedded in skeletal muscle, and activating them enhances muscle contraction. That is why an asthma patient might take a hit of an albuterol inhaler and suddenly find their hands are shaking uncontrollably.
It's a very common presentation. And the other significant adverse effect of beta-2 activation is hyperglycemia.
High blood sugar.
Right. Beta-2 receptors in the liver and skeletal muscles trigger the breakdown of glycogen into glucose. In a patient with healthy pancreatic function, the body just releases more insulin to handle the spike. But for a diabetic patient, this can cause a dangerous elevation in blood sugar that requires close monitoring and insulin adjustment.
Finally, we have the dopamine receptors.
In the periphery, dopamine receptors are predominantly located in the vasculature of the kidneys. Activating them dilates the renal blood vessels, increasing renal perfusion.
Which is huge in emergencies.
Absolutely. During a state of shock, when blood flow is compromised, this is incredibly important for protecting the kidneys from ischemic injury and acute failure.
So we've mapped out exactly what each molecular switch does in isolation. But in a true crisis, you often need to flip multiple switches simultaneously. The classic clinical example of this is anaphylactic shock.
Yes, a perfect example.
Anaphylaxis is a systemic collapse. You have a severe allergic reaction causing massive, widespread vasodilation, which makes the blood pressure crash. You have intense bronchoconstriction, making it impossible to breathe. And you have glottal edema, where the airway physically swells shut.
It is a terrifying cascade. And the definitive, elegant cure is epinephrine.
Because it hits everything.
Exactly. Epinephrine is the drug of choice because it acts as that master key we discussed. By activating alpha-1 receptors, it aggressively constricts those dilated blood vessels to restore the blood pressure and dramatically reduces the swelling in the glottis.
Yes.
By activating beta-1, it stimulates the heart to improve cardiac output. And by activating beta-2, it forces those constricted airways back open. It chemically reverses every single fatal symptom of the anaphylaxis simultaneously.
It's just incredible. And because this is so critical, the text highlights specific patient teaching points for EpiPens, the epinephrine autoinjectors. Nurses must ensure patients understand that these devices are sensitive to extreme heat and light, so they need to be stored at room temperature in a dark place.
No leaving them in a hot car.
Exactly, no hot cars. But the most vital piece of education is about the drug's duration. The effects of an EpiPen injection will begin to fade in 10 to 20 minutes. Even if the patient feels completely fine, they must seek immediate emergency medical care.
This is so important.
Yeah, because once the epinephrine wears off, they are highly susceptible to a biphasic reaction where the anaphylaxis comes roaring back just as severely as before.
That specific teaching point saves lives. If they use the pen, they must call 911.
Now that we understand the chemistry and the receptors, looking at the specific adrenergic agonists isn't just a list of random facts anymore. It's clinical logic. You just look at what the patient needs and find the drug with a matching receptor profile.
Exactly.
We already established epinephrine, it's alpha-1, alpha-2, beta-1, and beta-2. It's a catecholamine. But what happens if a patient taking an MAO inhibitor for depression needs epinephrine?
That is a severe drug interaction. MAO inhibitors drastically reduce the amount of the monoamine oxidase enzyme in the body. Since MAO is what normally destroys epinephrine, a patient on an MAO inhibitor will experience intensely prolonged and exaggerated effects from the epinephrine.
So it just builds up.
Right, the dosage must be drastically reduced. Tricyclic antidepressants carry a similar risk because they block the reuptake of the drug, leaving it active in the synapse longer. Also, certain general anesthetics can sensitize the heart myocardium to beta-1 activation, increasing the risk of dangerous dysrhythmias if epinephrine is introduced.
Okay, let's look at another catecholamine. Norepinephrine. It activates alpha-1, alpha-2, and beta-1. Notice what is noticeably absent. It lacks beta-2 activity.
Right.
Why would we choose norepinephrine's over epinephrine? Because it doesn't hit the lungs or the liver. It does all the cardiovascular work of elevating blood pressure and supporting the heart, but it does not cause hyperglycemia. It is primarily used for severe hypotensive states in cardiac arrest, where airway compromise isn't the primary issue.
Then we have the evolution of asthma treatments, which is a perfect lesson in receptor selectivity. Historically, we used isoproterenol. It's a catecholamine that hits both beta-1 and beta-2 with no alpha activity.
If you visualize a patient given isoproterenol for asthma, it's easy to see the flaw. Yes, the beta-2 activation opens their airways, which is exactly what you want, but the beta-1 activation simultaneously causes their heart rate to completely spike.
It's a terrifying experience for a patient who is already anxious from struggling to breathe.
Definitely.
That is why albuterol revolutionized asthma management. Albuterol is a non-catecholamine that selectively targets beta-2. It opens the airways but largely spares the heart from that dangerous beta-1 overstimulation, provided it is kept at a therapeutic dose.
Let's move to dopamine. This drug is infamous in pharmacology because its receptor specificity changes entirely based on the dose you administer.
It is very unique.
Yeah, at a low therapeutic dose, it strictly activates dopamine receptors, dilating the renal blood vessels. Push it to a moderate dose, and it starts activating beta-1 receptors, increasing the heart's force of contraction. But if you push it to a high dose, it suddenly starts activating alpha-1 receptors, causing intense vasoconstriction.
And that dose-dependent nature creates a critical nursing implication. You administer dopamine to a patient in shock to support their failing heart and protect their kidneys, but if the infusion rate drifts too high, that alpha-1 vasoconstriction kicks in and actually clamps down on the renal blood vessels.
Oh, wow.
Yeah, you completely choke off the blood flow to the kidneys you were trying to save. Therefore, meticulous monitoring of urine output is a non-negotiable requirement for any patient on a dopamine trip.
Because if urine output drops,
the kidneys are in danger. And just like epinephrine, if the patient is on an MAO inhibitor, the dopamine dosage must be slashed, often by at least 90%.
a 90% reduction is staggering. It really illustrates how aggressively our gut enzymes normally chew these drugs up. If we just want to support the heart without worrying about the renal vessels or the alpha receptors, we use dobutamine. It's a catecholamine that is highly selective for beta-1 only, making it a targeted therapy for heart failure.
To round out the list, we have the remaining non-catecholamines. Phenylephrine is a selective alpha-1 agonist. Because it targets those vessels, it's widely used locally as a nasal decongestant or systemically via IV to elevate blood pressure.
And finally, ephedrine.
Yes, ephedrine is fascinating because it's mixed acting. It binds to all four receptors directly, but it also indirectly causes the nerve terminals to release more stored norepinephrine.
And because ephedrine is a non-catecholamine, it easily crosses the blood-brain barrier. It acts on the central nervous system, keeping the brain highly stimulated. That's why insomnia is such a famously reported side effect.
It effectively refuses to let the brain shut down for sleep.
To bring all of this together into clinical practice, we need to look at the major nursing implications. The very first thing the text emphasizes, backed by the Institute for Safe Medication Practices, is that 5-E adrenergic agonists are high-alert medications.
A high-alert designation means these drugs possess an immense potential to cause devastating, life-threatening harm if they are administered in error. They require independent double checks, continuous cardiac and hemodynamic monitoring, and constant vigilance from the nursing staff.
The most immediate physical danger to monitor for is extravasation. We touched on how an alpha-1 agonist leaking into the surrounding tissue causes localized necrosis. But what is the actual protocol when a nurse sees the IV site becoming pale, cold, and swollen?
The absolute first step is to stop the infusion immediately. You must halt the delivery of the drug.
Okay, stop the IV.
Then the standard clinical intervention is to infiltrate the affected tissue with a drug called phentolamine. Phentolamine is an alpha-adrenergic antagonist, an alpha blocker. It floods the area, sits on those alpha-1 receptors, and aggressively blocks the agonist.
Oh, that makes sense.
Yeah. This reverses the intense vasoconstriction, dilates the vessels, and restores life-saving blood flow to the tissue before it permanently dies.
That is the definition of a critical intervention. Finally, we need to consider how these drugs affect patients across the lifespan. When looking at pediatric patients, the text is clear. In life-threatening emergencies like anaphylaxis or cardiac arrest, there are no contraindications.
Yeah.
You utilize the drugs necessary to save the child's life.
Right. During pregnancy, though, the risk profile shifts. Dobutamine is generally considered relatively safe. However, drugs with strong alpha-1 activity, such as epinephrine and norepinephrine, induce vasoconstriction in the uterine blood vessels as well.
Which limits blood flow to the baby.
Exactly. This can severely restrict oxygen flow to the fetus. Albuterol, being a beta-2 agonist, relaxes smooth muscle, which means it can decrease uterine contractility. However, as always, in a life-threatening emergency for the mother, essential treatments must not be withheld.
And for older adults, the aging physiological system is highly susceptible to adverse effects. They're much more sensitive to the massive spikes in blood pressure, the tachycardia, and the tremors.
Very true.
Furthermore, alpha-1 agonists cause contraction of the muscles in the prostatic capsule and the bladder sphincter. In older populations, especially men with enlarged prostates, this can precipitate severe urinary retention.
It is a constant reminder that every time you administer these sympathomimetics, you are manipulating a delicate, deeply interconnected systemic balance.
I think that is the most profound takeaway from all of this. We're so used to thinking of the nervous system as a fixed circuit, but it is remarkably responsive. If you understand the chemistry of the key and the location of the lock, you can predict exactly how the body will respond.
It leads to an incredibly fascinating question about the future of pharmacology. We spend so much time engineering drugs to be increasingly selective, trying to isolate just the lungs with albuterol, or just the heart with dobutamine. But because the sympathetic nervous system is so deeply intertwined with receptors sharing multiple organ systems, is it actually possible to ever create a 100% receptor-specific drug with absolutely zero side effects?
That's a great question.
Or is the body's evolutionary wiring simply too complex to ever fully isolate a single mechanism without the whole system reacting? It is something to ponder as you move from the textbook into real-world practice.
The human override switch is a complicated piece of machinery, but mastering it is what separates a medication administrator from a true clinical lifesaver. We want to send a warm, enthusiastic thank you directly from the last-minute lection team here at the Deep Dive for tuning in today. We hope this exploration made the dense pharmacology of adrenergic agonists finally click into place for you. Good luck on your upcoming exams. You are going to crush them. Keep learning, keep questioning, and we'll see you next time.